All right, everyone. Well, thank you very much for coming. My name is Dr. Bob Stern. I'm here from the Boston University Alzheimer's Disease Center. Just to give you a little bit of information about who I am, I'm a professor of neurology and neurosurgery at Boston University School of Medicine, and I oversee clinical research for things like Alzheimer's disease. And so I'm a researcher, I'm a teacher, I'm a clinician, you name it. I have way too many hats. Most importantly, I'm also a father of 4 kids and a husband, but I'm here today not just because I was asked to, but because I really want to. And what I want to do is I want to be able to teach you about Alzheimer's disease and dementia, and to give you some hope. And that's the title of the talk, is A Time for Hope. So what I want to do today is I'm going to go through all different parts of this whole very complex story and answer questions, because I'm here for you. I want to make sure that if you have questions, you get them answered. You should know that the sponsor of today, in addition to the fantastic Milton Council on Aging, is Senior Living Residences and the Compass on the Bay Assisted Living Memory Residence Program. I don't get paid by them. I'm not a paid speaker or advertiser. This is not an infomercial. But I get to tell you the honest truth, and that is that the work that Senior Living Residences does on behalf of people with memory disorders, dementia, Alzheimer's disease, is the best. And the places that they run, like the Compass on the Bay near here and all the other Compass programs and their additional programs, offer the very best care for people with dementia and memory difficulties, etc. So let me just start with a little story. The story starts with our beloved Red Sox, because every story should start with our beloved Red Sox. Isn't it wonderful to live in Boston? It's great. Absolutely love it. All right, so a couple weeks ago, there were a couple guys in my office, kind of like this. And one said to the other, "So I went to this fantastic restaurant with my wife in the South End. The food and service were great." And the other guy sitting next to him in my waiting room said, "I don't really want to talk to this guy." But he said, "Okay, so what was the name of the place?" And the first guy said, "Oh, I was afraid you were going to ask that. I don't remember. That's why I'm here to see Dr. Stern." But a little bit later he said, "Oh, but wait. What do you call that special flower that people give on special occasions?" The guy looked at him and said, "You mean a rose?" And he said, "That's it." And he turned to his wife and he said, "Rose, what's the name of the place we went to the other day?" All right, so why am I starting with a joke? Number one, because, it's the beginning of the afternoon, people are tired. It's always good to, start with something to get people moving. But it's also really important when dealing with this disease to have a sense of humor. It's critical. And so what is really needed out there for everyone affected by this disease, the person with it, the caregivers, the partners, the spouses, the adult children, the professional, everyone dealing with it must have a sense of humor. But there's a couple other things that also begin with H that are needed when dealing with this disease. What do you think? Another H word that is necessary for us to have when dealing with this disease. It's great. Simultaneously, I heard hope and help. Thank you. It works every time. I've heard other things too, like hugs, humility. It's amazing, all these H words. But humor, it's okay to laugh. It is okay to laugh. Some things that are tragic can also be kind of funny, and it's okay to laugh. It's important. Hope, without hope, we can't get up in the morning. We can't move to the next day. And so it's critical to have some hope, and that's what I'm going to hopefully provide you with today. And help, it's critical to have help in this journey. If any of you are going through it yourselves, with your spouses, with friends, family, it's critical to have some help. So, this is a test. You won't be allowed to leave today unless you answer this correctly. So, for those of you who can't see it well, it's an older Superman, wrinkles and all, about to jump out the window to fly, to save the day somewhere. And he says, looking back to his wife, "Dang, now where was I going?" And on the bottom it says, Superman in his later years. So the test for you is whether this is true or false. Is it just Superman in his later years, meaning this is what would happen to anyone? Or is there something wrong with him? So by show of hands, how many people think there's something wrong with Superman by not being able to remember where he's going? How many people think this is just Superman in his normal, older years? How many people are afraid to raise your hand? It's in between, someone said. Well, if someone really forgets something like that, something important, there's something wrong. Because it's a myth. It's really a myth in 2013 that if you live long enough, you'll get Alzheimer's disease or dementia or some kind of significant memory problem. It's just not true. Alzheimer's disease and other causes of dementia are not an inevitable part of aging. Almost everyone experiences a little bit of mild forgetting, a little bit of slowing down. Just like, our bones creak a little bit, it's harder to get up, our sight might not be as great. So our brains are a little bit slowed down. But not everyone develops an actual brain disease that results in significant problems with memory and judgment, personality, behavior. Millions and millions of people reach very old age, 50. It's a joke. Reach very old age, 90s, hundreds now, without any problems that are really significant with their memory and other cognitive skills. And so, if there's one thing I want you to get out of today, it's that significant cognitive decline is not a normal part of aging. When there is something going on, when there is some kind of significant decline, there is indeed something wrong. And what is that something wrong? What do we call it? Dementia. And so dementia is, this is the definition of it, okay? Pay attention, because I'm going to refer to this later. Dementia refers to the new loss of memory functioning and at least one other kind of cognitive skill that's bad enough to get in the way of daily life. So that's all dementia is. It's a clinical phenomenon. It's a clinical problem of having a memory problem and at least one other difficulty, and it's bad enough to get in the way of daily life. Okay, to get in the way of independent living. We used to refer to it as senile. A lot of people still do. Anyone here remember their Latin? What does senile really refer to? What's the Latin root for senile? Senile just means old. But someone over here said forgetfulness. And that says it. What's happened in our culture is that a word that only means old has now taken on a new meaning of having lost your memory and other cognitive skills. That's not really true. Getting old doesn't mean you lose it. But having dementia is the term that refers to that problem of forgetfulness that's bad enough to get in the way of daily life. Now, it's important to know that dementia itself is not an illness. Dementia itself is not a disease. It's kind of like having a fever. If you have a fever, what's wrong? What does it tell you? You're sick! That's all. Having a fever tells you you're sick. Having dementia Says there's something wrong with your brain. But it doesn't say what. And so there's lots and lots of causes for dementia. Some of them are reversible. Things like overt hypothyroidism. Things like certain vitamin deficiencies, like vitamin B12 deficiency. Clinical depression is a brain disorder that can result in dementia. But if you treat these kinds of things, these reversible things, the dementia will go away. But that's not really what we're here talking about. We're here today talking about what we refer to as neurodegenerative diseases. Brain diseases that destroy the brain tissue, slowly but surely. Neurodegenerative diseases that lead to, eventually, dementia. And there's a whole bunch of these types of brain diseases: frontotemporal dementia, vascular dementia, Lewy body disease, chronic encephalopathy, all these different things. But the most common cause of dementia is Alzheimer's disease. So the most common cause of the clinical problem of having dementia is Alzheimer's disease. So here's the second thing I want you to really remember. Dementia is a clinical syndrome, not a disease. Alzheimer's is a brain disease that, when it gets bad enough, leads to dementia. And so it's not like you have a little bit of dementia and it gets bad and it becomes Alzheimer's disease. Even though that's how a lot of doctors refer to it, and a lot of people think, yeah, it's okay, you just have a little bit of dementia. That's not it. It's you can have a little bit of Alzheimer's disease, and when it gets bad enough, it will lead to dementia. Okay, does that make sense? All right. Why are we even talking about Alzheimer's disease? Well, because it's an epidemic. It is wild how many people have it. Every 60 seconds in our country alone, someone develops the dementia from Alzheimer's disease. In our country alone, there's around 5.5 million people with dementia from Alzheimer's. And that's growing like this. So by the year 2050, there'll be 16 million people with dementia from Alzheimer's disease in our country alone. Why is that? It's because we're getting older as a population. Us baby boomers are turning age 60 at a rate of 330 an hour. That means a lot more seniors in our society. So I'm going to tell you something, and then I'm going to tell you later that it's a little complicated. Growing old is the biggest risk factor for Alzheimer's disease. Okay? But that doesn't mean getting old causes it. It just means that the older you get, the more likely there is a chance to show it. And so with our aging population, these numbers are going to get huge. Right now, in 2013, 1 out of 8 people aged 65 and older has dementia from Alzheimer's disease. Scary, 1 out of 2 people age 85 and older has it. 1 out of 2 people. That's the glass half empty. The glass half full is 1 out of 2 people don't have it. It's the 6th leading cause of death in our country. And it's the only cause of death in the top 10 causes of death that can't be prevented, can't be cured, and right now can't even be slowed down. Between 2000 and 2008, for those of you who can see the slide, there was a 66% increase in mortality, in deaths from Alzheimer's disease. And at the same time period, there was a huge decline in deaths from stroke, prostate cancer, breast cancer, heart disease, HIV/AIDS. And at the same time, money to the National Institutes of Health have been going up for those other diseases and haven't touched anywhere near it for Alzheimer's disease. I mentioned mortality, deaths by the disease. Well, in fact, it is a fatal disease. People sometimes are surprised by that. The average time from diagnosis to death is around 8 years, but that's the average. Some people in the last 20 years with the diagnosis can be very slow. Other people it can be very short, months or a year. Why is that? Well, it depends on how advanced the disease is in the brain at the time of diagnosis. Because you don't just all of a sudden, poof, get it. And you go to the doctor and they say, yes, right, you just got it. It's a slow thing. I'll describe that in a minute. The most common causes of death in people with Alzheimer's disease are infections, things like pneumonia. But some people just die from the disease itself because it destroys the brain so much that someone might just die in their sleep from the brain not functioning. Let's make this more personal. Let's talk about the impact of Alzheimer's on the individual. This is my favorite way of describing the impact of Alzheimer's on the individual and also on the caregiver. If you can't see it, it's two dinosaurs on a little island at the time of Noah's Ark, and Noah's Ark is leaving with all the pairs of animals, and one dinosaur says to the other, "Oh crap, was that today?" But seriously, this is really the impact on the individual. This is a self-portrait by an absolutely fabulous portrait artist named William Utemohlen. Utemohlen, he actually had Massachusetts roots. He was the artist in residence at Williams College in Massachusetts. But he was an internationally known portrait artist. I know that because once I was giving a talk like this in New York City as a fundraiser, and one of the people in the audience blurts out, "Oh, William, he did my portrait in Paris." So it's pretty good. You can see from this picture, for those of you who can see, it's pretty darn good. The problem is this was 1967, and 10 years later, or 9 years later, he was diagnosed with Alzheimer's dementia. He had profound memory problems at that time. But look at this. It's still unbelievable. This is someone with Alzheimer's dementia. And look at how great that picture is, what he could do. Unfortunately, the disease was starting to rapidly progress at that time. And 1 year later, that's as good as he could do. I apologize for those who can't see it well. You would see that a self-portrait by this gentleman with dementia is getting progressively awful. This is just 1 year later. 1 year later. 1 year later, that's the best he could do, this incredible artist. He has since passed away. But I'm showing you these pictures to point out a very important issue. We think of Alzheimer's disease as purely a memory disorder. It's not. It's a brain disorder that destroys the entire brain. And so everything that we do, everything who we are, is controlled by the brain. That's what makes it so magnificent. The brain controls our movements, our speech, our thoughts, our memory, our personality, our behavior, our ability to judge things and make decisions, our ability to see things accurately. Everything we do as a human being, as an animal, is controlled by the brain. So the symptoms of this disease, when they do start, most often actually do start with problems with short-term memory. And by short-term memory, I'm referring to the inability to recall something from just a few minutes ago, or the inability to make a new memory. So the person with this disease and this memory problem from the disease has this rapid forgetting of information. They may repeat the same thing over and over again. But what's important to know is that long-term memory is retained. So the ability to remember details about the war, your marriage, your wedding, your first grade teacher, your violin lessons, all that stuff, that's really hard to lose. The person with the significant memory problem from Alzheimer's disease can't learn something new, because the part of the brain that's responsible for learning something new is hurt early on. The part of the brain is called the hippocampus. It's way in the middle of the brain. And that hippocampus starts being destroyed by the disease very early and starts shrinking. And if the part of the brain that's responsible for making new memories is hurt, it's impossible to make the new memory. But it's not just memory problems, like I said, it's also language difficulties, having really bad problems coming up with the right word for something. But also problems with things like planning, organization, multitasking, decision-making, judgment, all those things that we do every day. Then there's something really interesting and very problematic that occurs, and that there's a difficulty with awareness, with insight, with the ability to actually be aware that you have the problem. Yeah, people know this. You've seen it in people you know. It has a fancy word called anosognosia. Anosognosia is the neurologic term, fancy kind of medical term, for the neurologically based inability to be aware that you have a neurologic problem. Let me say it again, because it's a wild concept. This lack of awareness is caused by anosognosia, which is the neurologically based problem that leads to the inability to be aware that you have a neurologic problem. What a concept. That makes it very hard for others around the person with Alzheimer's, but doesn't necessarily make it hard for the person with the disease, because that person can't remember and doesn't have awareness. And so it doesn't make any sense for the people around them, all of us, caregivers, friends, family. It doesn't make any sense to say, remember, dear, you have this problem. No, they don't remember, and no, they're not going to be aware. The order of these changes, the order from memory difficulties and language difficulties and problem solving and awareness, all those things, it doesn't follow the same order in every person. And in fact, in our field, we say, if you've seen one Alzheimer's patient, you've seen one Alzheimer's patient. So a lot of you here are trying to figure out, do I have it or don't I? Boy, this is sounding scary. Or does my loved one have it or not? Well, let's kind of distinguish between normal brain aging and the problems from Alzheimer's disease. In normal aging, we might have a problem coming up with something, retrieving information. What was that movie we saw last week? But it's there. If you get enough time, if you have enough cues, multiple choices, talking about it, it will come, right? There's insight. You're aware that you have a problem. There's no change in daily functioning, because remember, to have dementia means you have a problem with daily functioning. In normal aging, there may be a minor delay in coming up with the right word for things, but it's not bad enough to get in the way of your speech. It might, every so often, a couple times a week, you might forget, no, it's not forgetting, it's just a language problem, coming up with the right word. Now, here's everyone's favorite. Everyone, as we get older, has problems coming up with people's names. Big sigh of relief. I know for me, I can't remember anyone's names. It's getting worse. But that's not necessarily part of a problem. That's just something that happens. And then there's something called visuospatial functioning, the ability to deal with spatial information and distances and angles and all those kinds of things, putting things together with your hands. Those things are retained in normal cognitive aging, normal brain aging. So in contrast, the person with dementia from Alzheimer's disease, their memory problem is that they can't store the information. So no matter how much cueing, no matter how much time, no matter how much multiple choice, no matter how many times you say, remember, dear, we did this, it's not there. And so there's that rapid forgetting of information. And the person with Alzheimer's dementia may have poor insight, lack of awareness. They're going to have problems with daily functioning, paying bills, using the telephone, driving, etc. There may be significant word-finding problems where the speech gets kind of empty because there's all these pauses for the right words. And there may be problems with visuospatial difficulties, not being able to navigate well or deal with distances. And then there's actually changes with our emotions and behavior. Very common, there's a problem with apathy, meaning there's a lack of caring, a lack of emotion about things. It's just kind of like sitting there like a lump on a log. And withdrawal. All right, change gears a bit. Some of you may have heard that our country has a little bit of economic difficulty these days. I think I hear that maybe every so often. There seems to be a fiscal cliff every week. Well, Alzheimer's disease plays a huge, huge role in our economic crisis right now. Let me tell you a little bit more. The national cost of taking care of people with Alzheimer's disease is about $200 billion a year. That's a quarter of that entire stimulus bill. And because of the numbers of people with the disease, the amount of money that's expected to be our national cost for Alzheimer's is going to be over $1 trillion. Think about Medicare and Medicaid. Last year, in 2012, there were $140 billion spent to take care of people with Alzheimer's dementia. 1 out of $4 in Medicare was spent to take care of problems resulting from the Alzheimer's disease. 1 out of 4 Medicare dollars. So when we talk about Medicare going broke, think about it. 1 out of $4 spent just to take care of the specific things resulting from Alzheimer's. The average lifetime cost for someone with Alzheimer's disease is around $174,000 for the person. But with assisted living programs, with nursing facilities, I hate to say this, Compass on the Bay, but it's true. There's more and more people needing more and more special care things, and those special care programs are very expensive. The average assisted living memory care facility is $57,000 a year. And then businesses. We talk about trying to make sure that our economy is helped by making sure businesses aren't spending too much money. The cost to businesses, both large and small, because of employees who are caregivers for people with dementia, is $37 billion a year. Why? Because the caregivers have to take time off from work. And the caregivers get sick themselves because of the incredible stressors of being a caregiver. Let's talk about caregiving for a minute. Caregivers can be spouses, partners, they can be adult children, grandchildren. They can be members of faith communities. They can be members of the community like a council on aging. They can be friends. They can be other relatives. There are 15 million caregivers in this country. 15 million unpaid family dementia caregivers in this country. And the caregivers don't just suffer emotionally. They also suffer physically. But perhaps most important, there are lost dreams. You expect to be able to go through older age with your loved one, to do all those things you hoped after retirement. And then the individual becomes worse and worse because of their brain disease. But, really, really important, the person with Alzheimer's dementia is not dead. The person is not dead, and both the patient and the spouse or care partner can benefit tremendously from maintaining emotional and physical closeness. What I want to do is I want to run a short video from Good Morning America. And I'm going to try to put my microphones near the speaker on my computer so you can hear it okay.
I know it sounds cruel, but if he's going to do something, he should divorce her and start all over again. But what about this? If you respect that vow, but he said, death do us part, this is the kind of death.
With all due respect to Pat Robertson, I find that statement absurd, naive, and inhumane.
He said, in his view, the person's dead anyways. That's a very different thing. The person isn't dead. Not at all. Let me tell you a story about Rita and Saul Rogers. Rita and Saul were local people in Massachusetts. They'd been married for well over 60 years, and poor Rita developed Alzheimer's disease, and it was getting pretty bad, and she had to go into a nursing facility in Needham. And she was one of these really awful patients. She was agitated, combative, did not speak, would not get out of bed. But no matter what, her husband, her dear Saul, would come every day and sit next to her and hold her hand. Every day. No matter how grouchy, combative she was, she wouldn't talk. He sat there and held her hand. Then one day he said, you know, I need to do something about this. So he went to the nursing staff and he said, would it be okay if I lie in bed next to my wife? And he said to make love to her, which he meant to caress her, to kiss her, to tell her that he loved her. Well, the sad part was they had to actually get permission. And they had to have a meeting and decide whether it would be okay. And then they had to rearrange the room. Well, finally, dear Saul was able to. And guess what? Very soon thereafter, Rita started speaking. She got out of bed. Her whole demeanor changed. She wasn't combative and agitated. Now, it didn't change her disease at all. She still couldn't remember anything. She still couldn't think well. But her heart was touched. That other H word. Her heart was touched by being able to feel that love from her husband, even though she couldn't remember his name. So, Saul thought this was fantastic. Imagine his quality of life, not just hers. Imagine his quality of life. How much better that was. Well, Saul thought, if that's working, let's try something else. She loved old Dean Martin songs. So he brought in a record player. Remember record players? And brought in some old albums from Dean Martin. When the moon hits your eye like a big pizza pie. She started singing. And then would sing through the hallways. This woman who was agitated, combative, mute, wouldn't get out of bed, is now singing in the hallways. She's since passed. But imagine what this was like. And imagine what Alzheimer's disease is. It is a disease of the brain that's destroying so many things. But our hearts are still able to be touched. All right, I'm going to do a little bit of science. For time's sake, I'm going to just do this very quickly. Alzheimer's disease, as I've been saying, is a brain disease. And it was discovered by Dr. Alzheimer in the early 1900s. And what he found when he looked at the brain under a microscope of one of his patients who had awful memory problems and personality changes, he saw these things that he referred to as plaques and tangles. Just remember plaques and tangles, where plaques are made up of this protein that goes awry called amyloid, and tangles are made up of a protein that goes awry called tau. So just remember plaques and tangles. The way to think of it is plaques are around the nerve cells and tangles are inside the nerve cells. And together they destroy the brain cells. And as the brain cells get destroyed, then you lose brain tissue, it becomes atrophied. So for those of you who can see the slide on the left is a picture of a healthy older brain. And then on the right a destroyed brain from Alzheimer's disease, where you can see the shrinking, the atrophy, because those plaques and tangles led to the death and destruction of the brain tissue. This doesn't just come out of the blue. It's not like all of a sudden, poof, your brain shrinks. It's likely that these plaques and tangles actually begin years and years before there's even the first symptom. Years and years. In fact, a recent study found that the plaques might start around 20 to 25 years before their symptoms, which means the disease is there slowly but surely in probably half the population or more. But it's not until enough brain tissue is hurt in the specific areas that the symptoms begin. And when those symptoms begin, we refer to it as mild cognitive impairment, or MCI. And all that is a description of someone who has a complaint of having memory or other difficulties. And if you test them with standardized tests, they actually are doing badly compared to their age, what we would expect. But it's not bad enough to get in the way of daily life, and so it's therefore not dementia. So it's a problem, but not bad enough to be considered dementia. So we refer to this as MCI. So how do we diagnose these things? How do we even know if someone has this? Well, a lot of you have probably heard that you can't diagnose Alzheimer's disease until someone dies. You've heard that, right? Well, I used to use this picture. For those of you who can see it, it's a finger stick, blood test. I used to use this picture to say, there ain't no way we're ever going to have a blood test like this for Alzheimer's disease. Now I use it because, in fact, we have hope. There are new things on the horizon. Yeah, there are new things on the horizon that will allow us to actually diagnose the disease by blood tests. It's not there yet, but boy, is it getting close. But for now, how do we make the diagnosis? It's a clinical diagnosis, meaning without looking at the actual brain, we can't be completely sure that the person has this disease. And so the current best diagnosis is based on getting a really good history, doing a good clinical examination, perhaps getting some pictures of the brain like a CAT scan or an MRI to just be able to rule out something else causing the difficulty, and then formal memory and cognitive assessment, neuropsychological testing. In other words, the most important thing is to spend time with the doctor, going through the whole history. But not just the patient. Why? The patient has lost awareness, perhaps. The patient can't remember that they're having problems. So it's really important that a loved one, someone who's a good informant, talk with the doctor. And when people go to the doctor, all too often these days, still, in 2013, when they go to their primary care doc, they hear these very all too common responses to them coming with complaints. They hear, "Don't worry, it's just a little bit of dementia," which is implying, don't worry, it's not yet Alzheimer's disease. And now you all know that's just wrong. Or they might say, sorry, I think it's Alzheimer's disease. Have them take this Aricept, this medicine, and call me in a few weeks. We'll increase the dose. And you know what? You should probably get his affairs in order. Absolutely no hope or help or heart. It's basically, okay, it's a death sentence. Go away. Or perhaps we hear this, it's just normal aging. Usually said by an older primary care physician who just doesn't know better. It's not to blame primary care docs. They have a lot to do. They have a 10-minute examination time and a whole lot that's coming out about the brain and every other disease. But we're trying so hard to educate all doctors about how to pick up on this disease. For those of you who can see it, this is just a little funny slide. It's a doctor sitting at his desk with a nurse coming in, and she says, well, if you're stumped, why not write an illegible prescription and hope the pharmacist comes up with something? Well, you know, that being stumped or not feeling like you can make the diagnosis is changing. Now, we at places like my Alzheimer's Disease Center, that's all we do. So I know that I'm right 96, 97% of the time when I make a diagnosis. And I know I'm right because we follow people after they die and they agree to donate their brains after they die, and we examine them and we know who has what. And so because we do this every day, in and out, we know how to diagnose the disease just based on clinical information. But the average clinician can't do that easily. But even for us and for the whole kind of medical world, things are changing, and again, huge hope. Why? Because we have these things called biomarkers. Think about for things like breast cancer. You can pick it up with a mammogram. Think about prostate cancer. You can pick it up through a PSA test. Think about having risk factors for heart disease. You can pick it up by cholesterol levels, etc. With Alzheimer's disease, we never had any tests. Now we do. And so we can do things like special MRIs that measure that hippocampus to test for shrinking. We have ways of looking at spinal fluid through having a spinal tap, which these days is actually not a bad thing. It's a different story when getting a spinal tap. And we can look at those tau and amyloid proteins that cause the plaques and tangles in the spinal fluid. We can do special PETs to look at the metabolic activity in the brain. But now we can do even better things. We can have a special PET scan that can actually see the amount of amyloid in someone's brain while they're alive. There's 2 now that are approved by the FDA. But sadly, Medicare won't pay for them yet. I was just down in Washington last month arguing to the heads of Medicare and Medicaid services, saying, these things are critical. People are in desperate need of being able to have a good diagnosis. Hopefully they'll change their mind. For those of you who can see it, this is an idea, this is an example of one of these PET scan tests. On the left are pictures of the brain of a healthy older person without any lighting up of the amyloid that's being detected. And on the right is the brain of someone with Alzheimer's disease, and all the red and yellow, those are the parts of the brain with a whole lot of amyloid in it. So we are seeing the disease while someone's alive. And then the next step would be to be able to see the tau, something that people thought we wouldn't be able to get to for years. And in fact, some colleagues of mine have developed a way now to see the tau while someone's alive, to see those neurofibrillary tangles, the tangles inside the nerve cells. This is all just happening in the last year. And so we can now, with these special tests, diagnose the disease early. We can diagnose it early. Prior to any symptoms. And so a lot of you are then sitting there saying, why would I want to know? Why would I want to know if I have Alzheimer's disease? Especially if there's nothing that can be done. Well, there's a whole lot of reasons to want to know. One of the most important reasons in my mind, though, is to help research move forward. Because unless we can try new medications early in the disease before the brain has lost too much brain tissue, we won't be able to succeed in our research. And so we need to try these new medications out early in the disease in people who we know have it, so we can develop the new medications that will be successful in early stages of the disease. Let me put it this way. Again, I apologize, there's so many visual things here. If you can't see it, I'll be glad to go over them close up later. But here we have a picture of what normally happens in Alzheimer's disease. The yellow diagonal line is showing the typical SAD trajectory, where up on the top left is preclinical, meaning you have the disease in your brain, but you don't have any symptoms at all. And then it's slowly getting worse, more and more brain tissue is being hurt by the disease, and you go through that kind of fuzzy period of mild cognitive impairment. And then it gets worse, and it causes you to not be able to function independently. And what do we refer to that as? Dementia. And then sadly it gets worse and eventually the person will die. So, wouldn't it be cool if we could come up with a cure after someone's symptomatic? Yeah, but I don't think that's going to happen because once brain tissue's gone, it's gone. But could we give something to people after they're symptomatic, after they have dementia, that might give them a little bit of boost, improve their symptoms a little bit? Well, in fact, we already have that. That's why it's important to get diagnosed now with even dementia, because there are medications that do work somewhat. Things like Aricept and Razodine and Exelon and Namenda. These are all medications that work a little bit for a little bit of time in some people. That's not a great bit of PR for them, is it? But it's what we have right now. A little bit of symptomatic relief for a short period of time. So it's not great, because those things aren't doing anything to the disease. So wouldn't it be really cool if we could slow the progression of the disease? So we could stop the amyloid and the tau from getting worse and worse and stop the brain from being destroyed. And that is where we are now with new drugs that are being studied. And then, of course, it would be great if we could prevent it from happening in the first place. But think about this. Instead of starting treatment after someone has dementia and a whole lot of symptoms, and it slows down the disease, and that's great. It improves quality of life for a while. It extends the person's life. But what if we could diagnose someone early? Like I've been saying, with those biomarkers, with those special scans. What if we could diagnose someone early? Start a disease-modifying drug. Well, what's happened is it turns into prevention. Because if you start before the symptoms, or at the very early stage of the symptoms, and the drug's working to slow it down, the person will never have the symptoms, or they won't get bad. Tomorrow morning at 5 o'clock in the morning, I leave for San Diego for what's called an investigator meeting. It's for all the researchers involved in a new study. It's a study that is doing just this. It's called the A4 study, where we're going to be taking lots and lots of people who are concerned that they might have this. We then give them one of those PET scans to see that they definitely have tracers of that amyloid. And then we put them into this clinical trial to see if we can slow down the disease so they never get bad. That's happening starting tomorrow. That's why 2013 is a time for hope. There were recent trials around a year ago that got a lot of attention that failed. You know, I heard about, there's no hope for Alzheimer's disease treatment because these treatments failed. Well, in fact, they didn't really fail. They were started too late. They started when people already had significant dementia. And so too much brain tissue was already lost. So no matter how good they weren't going to work successfully. And so it could be that starting the right medication at the right stage of the disease is what's going to do it. And that's where we are now. New, exciting clinical trials. The one I'm going to tomorrow to start. We already have one that we're running for people who have mild cognitive impairment but don't yet have dementia. Again, one of these new exciting studies that are going to hopefully move to the point of being able to stop the symptoms from progressing. But there is new hope for prevention. In addition to the things I was just talking about, what's good for the heart is actually good for the brain. What's good for the heart is good for the brain. So I'm sorry, but you have to get rid of all that high cholesterol food. You also have to make sure that diabetes is either controlled if you have diabetes, or you prevent getting it in the first place. Diet can actually help slow down the disease from moving forward. It won't prevent it completely, but there's lots of really good research that suggests that eating berries like blueberries and other dark berries might actually have an impact on the brain and help this disease from going bad, from tearing your brain apart. There's other research that suggests that those omega-3 fatty acids, the fish oils, that those might actually be really good for your brain. There's data that suggests that olives and olive oil can be helpful. There's a picture of broccoli. I'm not really sure why I put that up because there's no data to suggest that broccoli helps, but how could it be bad? Most of the research looks at the Mediterranean diet, meaning things like, things like eating a lot of legumes and, and nuts, fruits and vegetables, olives and olive oil, fish high in those omega-3 fatty acids, and very little red meat. That's the Mediterranean diet. And it's been shown now over and over again to actually have an effect on the brain and perhaps slow down the development of the disease. What about this one? Everyone's favorite. It's a glass of wine up there. Let's have a show of hands. How many people think that drinking alcohol is helpful in preventing Alzheimer's disease? How many people think it would be harmful? How many people wish that it would be helpful? Well, in fact, the recent research suggests that a little bit might be good for you. That moderate alcohol consumption of around 1 or 2 drinks a day, if you're an average weight person, if you weigh 80 pounds, you should not be drinking 2 drinks a day. But if you have no other contraindications, no other things like liver disease, kidney disease, diabetes, or out-of-control diabetes, if your doctor says it's okay to have alcohol, then the research does suggest that 1 or 2 drinks a day might be helpful. But any more than that is actually bad for you and can accelerate the dementia. And then, excuse me, once there's cognitive impairment, once the person starts having the problems, continued drinking can worsen it. But then you have this very important moral kind of question, ethical question. The person has this disease, it's getting worse, and they always loved their martini at the end of the day. Or if you're in an assisted living facility, and something that makes you happy was having that glass of wine at the end of the day. Is it okay or is it not okay? Something that people have to decide. And then there's the question of red wine. Red wine actually has a special chemical in it called resveratrol that itself is very helpful for the brain. The problem is you have to drink around 2 gallons of red wine a day. But you can actually get this chemical at a like GNC kind of store and take it, and maybe it will help. And then things like losing weight. So sorry, there's lots of evidence that losing weight is helpful. Being fat earlier in life might be harmful. Exercise is, excuse me, over and over again is found to be very helpful for the brain, and in particular Alzheimer's disease. So walking, half an hour a day, doing something aerobic is great. There's actually evidence in mice, in animals. So you have these little mice that are bred to get Alzheimer's disease. We have mice models of Alzheimer's disease. And you put half of them on one of those little rotary kind of treadmills, and the others, they watch TV all day and eat bonbons. I don't know what they do, but they don't exercise. And the ones that exercise actually have less amyloid plaques in their brain. So there's lots of good evidence that exercise, the right diet, like the Mediterranean diet, making sure your heart health is good, all of those things might have a great impact on slowing the progression of Alzheimer's disease. Then comes the question that people always are interested in, especially at places like this. What about intellectual activities? Should I be doing my crossword every day? Well, if you've been doing the crossword every day for the last 50 years, it's not going to help your brain anymore. It probably did a lot good then. But what the research shows that what works best is shaking it up a little bit. Try new things in new ways. So if you did crossword every day, try doing Sudoku. If you're a reader, try reading a different kind of book. Take up a new language. Take a new route if you drive. Take a new route to the kids' house or to work. Try new recipes. Don't just keep cooking the same thing. Try reading a different genre of book or going to a different genre of movie. Start a new hobby or rekindle an old one. In other words, just doing something new. And then very, very important is social interactions. Keep being social And if you're not social, if you don't have a good social network, do what you can. Try to have something in your life that interacts with other people. And believe it or not, that's been shown to actually prevent the disease from moving forward quickly. So, with all this, what's needed? Well, we're getting a lot older, with a much bigger older population in our country. And now that we have hope for new disease-modifying drugs, people are going to be living longer with the disease. And so we must do things that will improve quality of life for everyone involved, the caregivers and the person with the disease. What does that translate into? We need more and more support. More and more support. We need more facilities. We need caregiver support and respite for the caregivers. We need adult daycare, which you have here in Milton, which is fantastic. We need more of it that's specialized for dementia and personalized for the age of the individual. Having someone who's 55 years old and healthy otherwise, except having memory difficulties, in the same adult daycare as a 90-year-old who's frail, it doesn't necessarily work. And we also need more compasses on the bay. We need more of these assisted living memory residences that can truly provide scientifically based programming that will fill the person with quality of life and a longer, healthier life. These things cost money. We need to fill people's life with music. There's research that shows that music can actually improve someone's memory with Alzheimer's disease. Well, we heard earlier with Rita and Saul that music improved her quality of life. But there's actual research that shows that using music might actually improve memory. It happens to be my own son, Nick Simmons-Stern, who did that research. I've got to share with you this. Last week I was giving a lecture in Cape Cod for a big professional conference on Alzheimer's disease. And there were 4 speakers at this big all-day conference. I was one of them. I do that often. I frequently do those things. One of the other 4 was my own son. That was the coolest thing. There's also the use of arts in general. And all the senior living residences and Compass program use arts in a very appropriate way. There's a movie called I Remember Better When I Paint that you can get on Amazon, or perhaps Milton would like a copy. We can do a showing here sometime. But it's all about the use of arts in Alzheimer's. What else is needed? This is what I want to end in. We need people to participate in research. It's not just for us researchers. Participation in research can actually allow people to play a more active role in their own health care. It can allow people to gain access to potential new treatments before they're widely available. It allows people to receive expert care at great medical facilities at no cost. One of the real important things, though, is it makes a connection. Going through this disease for the person with it and the care partners is a very lonely, very difficult journey. Participating in research at a center where people actually understand it, where they really get it, will make someone not feel like they're doing it alone. And, very importantly, it helps people maintain a sense of hope. Not just for themselves, but also for future generations. We need to do something critically and quickly. And the only way we can do that is by having people participate in research. And there's a research study for everyone. If you look in the middle of that newsletter in front of you, the red and white thing, in the very middle page, there's a listing of all the research studies. Some of them we don't do anymore. We have new ones on top of those. We always have new and different kinds of research studies. And there's a research study for everyone. So what I want to leave you with is this idea. Just one. And what I mean by that is all I need is one person from today's lecture to participate in research. And you have then made our path to finding great interventions and great new changes to this disease You've helped us get there. People are always shocked that we at one of these major Alzheimer's disease centers and every other one around the country are desperate for research participants. We're one of the 29 centers around the country funded by the National Institutes of Health to study Alzheimer's disease. Harvard has one of the others. There's 27 around the country. Every one of ours are desperate for people to participate in research. I don't know about you, but I know people who have cancer participate in clinical trials immediately. They're always there to participate in research. My first wife died of cancer many years ago. I know immediately we were in clinical trials. Well, Alzheimer's disease is another fatal disease that we'll have important things that we can do to change it. So yes, even here in the Mecca of medicine in Boston, we are desperate for people to help us find a way forward. And so if today's talk could result in just one person getting enrolled in our research, then it will make a tremendous difference. So please help by signing up to participate, or not necessarily to participate, to just find out more. Tell a friend. Spread the word. You have our phone number and the email address in your newsletter. If you put your name and information on the sign-up sheet, someone will get in touch with you. If you didn't, but you still want to, or you think about it, or you haven't heard back from someone, take the newsletter home, contact us to find out what's there available for you. The Alzheimer's Association also has a great thing. If you know people who live in different cities and you want to find out what's available, contact the Alzheimer's Association, which is very easy to find in the phone book or online. It's alz.org, www.alz.org, and they have a program called Trial Match. And so finally, it all comes down to hope, but it also comes down to that help. And so if some of you are wondering, okay, now what do I do next? How do I get help? Well, the Alzheimer's Association, again, has help for everyone by having a 24-hour, 7-day-a-week hotline to answer questions, to help people in crisis with this disease, caregivers. They have support groups for the person with the disease, for caregivers. They have information, you name it. There's a private group that does incredible clinical evaluations right here in Jamaica Plain that you can go to. I believe they're listed in that newsletter as well. And then through our research center, we can do evaluations and give you and your doctor information about what's going on. Contact us if you have any questions. And so finally, the last thing that it all comes down to, remember that humor. Don't forget the humor. Don't forget that joke, of the rose. Keep smiling. Work with us to help find our way forward with it. Don't be afraid to talk about it. Go to your doctor. Come here. The Council on Aging has fantastic resources. The COMPASS programs have absolutely wonderful resources and facilities for people. So with that, I want to thank you all for really paying attention great throughout this talk. Thank you.